that affect a child's bones, joints, muscles, ligaments, tendons, and connective tissues. Unlike adults, children are still growing, which means their bones are softer, more flexible, and contain growth plates that are vulnerable to injury. Because of these developmental differences, children often experience different types of fractures, healing patterns, and orthopedic conditions than adults. Throughout this lesson, we will discuss both traumatic injuries, such as fractures and compartment syndrome, and non-traumatic conditions, including developmental disorders and musculoskeletal infections. As practical nurses, your role is to recognize abnormal assessment findings, provide safe nursing care, monitor for complications, educate families, and promptly report significant changes to the registered nurse or healthcare provider. One of the most important concepts in pediatric orthopedic nursing is that children usually heal faster than adults, but serious complications can still develop quickly. Conditions such as compartment syndrome, impaired circulation, or infection can permanently damage a child's limb if they are not recognized early. This is why frequent neurovascular assessments are one of the highest priorities when caring for a child with an orthopedic injury. As we work through this chapter, continue thinking about the nursing priorities you've learned throughout the program. Ask yourself, what assessment findings are expected? What findings require immediate intervention? What should be reported right away? What nursing interventions are within the LPN scope of practice? You will also notice that many NCLEX questions focus less on memorizing diagnoses and more on recognizing priority assessment findings, identifying early complications, and determining the safest nursing action. Those will be our focus throughout today's lesson. By the end of this chapter, you should feel comfortable recognizing common pediatric musculoskeletal conditions, performing an appropriate neurovascular assessment, understanding treatment options such as casts and traction, and identifying complications that require immediate action. These are all skills you are likely to encounter during pediatric clinical experiences and on the NCLEX PN. One of the most important concepts to understand in pediatric orthopedics is that children are not simply small adults. Their bones are still growing and developing, so they respond to injury very differently than adult bones. Many of the orthopedic conditions, fracture pattern, and healing processes we'll discuss today are directly related to these developmental differences. First, a child's bones are not completely ossified. Ossification is the process by which soft cartilage gradually becomes hard bone. Because this process is still occurring throughout childhood, pediatric bones contain more cartilage and are more flexible than adult bones. This flexibility means that children's bones can bend before they break, which is why they are more likely to experience green stick or buckle fractures rather than complete fractures. Another important feature is the presence of the epiphyses, also known as the growth plates. These are areas of cartilage located near the ends of long bones where bone growth occurs. Growth plates are actually the weakest part of a child's bone, making them particularly susceptible to injury. Damage to a growth plate can interfere with normal bone growth and may lead to limb length discrepancies or deformities if not recognized and treated appropriately. Whenever a child has pain near a joint following an injury, healthcare providers are always concerned about the possibility of a growth plate fracture. The periosteum, which is the tough outer covering of the bone, is also much thicker and stronger in children than in adults. This thick periosteum helps stabilize fractured bone fragments and keeps them from becoming significantly displaced. It also contains an excellent blood supply and many bone-forming cells, allowing children to produce callus much more rapidly than adults. A callus is the new bone tissue that forms around a fracture during healing. Because of this rapid healing ability, many pediatric fractures heal in just a few weeks compared with the much longer healing time seen in adults. The slide mentions that children's bones have a lower mineral content and greater porosity. While that may sound like weaker bone, it actually makes pediatric bones more flexible and resilient, allowing them to absorb force better before breaking. However, this flexibility also creates unique fracture patterns that are uncommon in adults. One point I want to clarify is that the wording on this slide could be misleading. Lower mineral content and greater porosity do not increase bone strength in the traditional sense. Instead, they increase the bone's flexibility, which helps reduce complete fractures, but makes children's bones prone to bending injuries and incomplete fractures. Finally, notice the discussion of bone overgrowth after fractures in children younger than about 10 years of age. Following a fracture, increased blood flow to the healing bone, called hyperemia, stimulates growth at the nearby growth plate. As a result, the injured bone may temporarily become slightly longer than the uninjured bone. In many children, this mild overgrowth actually helps compensate for any shortening that occurred when the fracture happened. This remarkable remodeling ability is one reason orthopedic providers often accept a small amount of angulation in young children that would require surgery in an adult. As the child continues to grow, the bone often remodels back toward normal alignment. For the NCLAX and in clinical practice, remember these key points. Children heal fractures faster than adults. Growth plate injuries require prompt evaluation because they can affect future bone growth. The thick periosteum helps stabilize fractures and promotes rapid healing. Children commonly sustain incomplete fractures because their bones are more flexible than adult bones. These developmental differences explain why pediatric orthopedic assessment, treatment, and healing differ significantly from what you've learned about adult musculoskeletal injuries. Understanding these concepts will help everything else in this chapter make much more sense. From an embryologic perspective, both the muscles and much of the skeletal system develop from the mesoderm, one of the 3 primary germ layers of the embryo. Although you won't be tested extensively on embryology in practical nursing, it's helpful to understand that many congenital musculoskeletal disorders occur because development is disrupted during this critical period. A significant amount of skeletal development occurs between the 4th and 8th weeks of fetal life, when the bones, joints, and muscles are first forming. Problems that occur during this period may result in congenital conditions such as clubfoot or developmental dysplasia of the hip, which we'll discuss later in the chapter. The musculoskeletal system has several essential functions. Most obviously, it supports the body and allows us to maintain posture. It also protects vital organs, stores important minerals such as calcium and phosphorus, houses the bone marrow where blood cells are produced, and works with the muscles to produce movement. As nurses, we often focus on movement because changes in mobility are one of the earliest signs that something may be wrong. An important concept in pediatrics is that locomotion, or the ability to move from place to place, develops gradually and predictably. Children achieve motor milestones in a fairly consistent sequence, although the exact age may vary somewhat from child to child. For example, infants typically progress from lifting their head to rolling over, sitting independently, crawling, pulling to stand, cruising along furniture, and eventually walking independently. Fine motor skills also develop progressively, beginning with grasping objects and eventually progressing to activities such as drawing, writing, and manipulating small objects. As nurses, we must always consider a child's developmental age when evaluating movement. A gait or movement pattern that is perfectly normal for an 18-month-old could indicate a serious problem in a 6-year-old. Likewise, temporary bowing of the legs or an awkward toddler gait may be normal developmental findings rather than signs of disease. Understanding normal developmental progression helps us recognize when a child is falling outside expected milestones. During every pediatric assessment, observation begins the moment you see the child. Before touching the patient, pay attention to how the child moves, walks, plays, and interacts with caregivers. Is the child reluctant to bear weight? Are they favoring one extremity? Do they have symmetrical movements? Is there limping, guarding, or obvious discomfort? Young children often cannot accurately describe pain, so changes in movement or willingness to play may be the first indication of an orthopedic injury or musculoskeletal disorder. For the practical nurse, observation is one of the most valuable assessment skills. A careful visual assessment may identify problems before the child ever verbalizes pain. Any abnormalities such as limping, refusal to bear weight, unequal movement, deformity, swelling, or limited range of motion should be documented promptly and reported according to agency policy. For the NCLX-PN, remember these key concepts. The musculoskeletal system provides support, protection, and movement. Bones and muscles function together. One cannot provide normal movement without the other. Motor development follows a predictable sequence, although the exact timing varies among children. Always compare a child's movement with what is developmentally expected for that age. Observation of gait, posture, symmetry, and movement is a critical part of every pediatric musculoskeletal assessment. These foundational concepts will help you understand why pediatric musculoskeletal assessments differ from adult assessments and prepare you to recognize both normal developmental variations and findings that require further evaluation. When a child presents with a musculoskeletal problem, the healthcare team uses a combination of the history, physical examination, diagnostic imaging, and laboratory testing to determine the cause of the child's symptoms. As practical nurses, you are not responsible for diagnosing these conditions, but you are responsible for preparing the child and family for testing, recognizing abnormal findings, monitoring for complications, and providing appropriate education. As nurses, one of your responsibilities is helping children successfully complete these diagnostic tests. Pediatric patients are often frightened by unfamiliar equipment and procedures. Age-appropriate explanations involving parents whenever possible, using simple language, and allowing children to ask questions can significantly reduce anxiety. For tests requiring sedation, you will also monitor the child closely for respiratory depression and ensure they meet discharge criteria before returning to the unit. For the NCLAX-PN, remember these key points. X-rays are usually the first test ordered for suspected fractures. CT scans provide detailed images of bone but involve higher radiation exposure. MRI is best for evaluating soft tissues, bone marrow, spinal structures, and infection, and younger children may require sedation. Ultrasound is commonly used to evaluate developmental dysplasia of the hip in infants and avoids radiation exposure. CBC and ESR help identify infection and inflammation, but are not diagnostic by themselves. HLA-B27 is associated with certain autoimmune musculoskeletal disorders, but does not confirm a diagnosis on its own. Understanding why each test is ordered will help you anticipate nursing care, educate families, and recognize how the results contribute to the child's overall diagnosis and treatment plan. The treatment of pediatric musculoskeletal conditions depends on the type of injury or disorder, the child's age, the location of the injury, and whether the problem is traumatic, congenital, infectious, or inflammatory. One of the unique aspects of pediatric orthopedic care is that children have an incredible ability to heal and remodel bone. Because of this, many injuries that would require surgery in an adult can often be managed with more conservative treatments in children. As practical nurses, your role is to provide safe nursing care before and after these treatments, monitor for complications, manage pain, perform frequent neurovascular assessments, educate families, and promptly report abnormal findings. Let's briefly review the major treatment options listed here. From a nursing perspective, post-operative care focuses on pain management, monitoring the surgical site for bleeding or infection, assessing circulation and sensation distal to the procedure, encouraging mobility as prescribed, and teaching families about activity restrictions and wound care. There are different types of traction, including skin traction, which applies the pulling force through the skin, and skeletal traction, which uses pins inserted directly into the bone. Children requiring traction often remain hospitalized because the equipment must maintain continuous, uninterrupted alignment. As nurses, maintaining proper traction is extremely important. The weights should always hang freely and should never rest on the floor or bed unless specifically ordered. The ropes should remain in the pulleys without obstruction, and the child's body should remain in proper alignment. Frequent neurovascular assessments are essential because swelling or impaired circulation can occur while the extremity is immobilized. Probably the treatment you will encounter most frequently is casting. Casts immobilize fractured bones, allowing them to heal in the correct position. Pediatric casts may be made of plaster or fiberglass. Fiberglass casts are lighter, stronger, and dry much more quickly than plaster casts, while plaster molds more easily around complex injuries. One of the highest nursing priorities after cast application is performing frequent neurovascular assessments. Remember the 6 Ps: pain pallor, pulselessness, paresthesia, paralysis, poikilothermia, meaning the extremity feels unusually cool compared with the opposite side. Increasing pain that is not relieved by medication, especially pain that worsens with passive movement of the fingers or toes, may be an early sign of compartment syndrome, which is a medical emergency. We'll spend significant time discussing compartment syndrome later because recognizing it early can save a child's limb. Families also need education about cast care. They should keep the cast clean and dry. Never insert objects inside the cast to scratch itching skin. Avoid trimming or altering the cast themselves, and report foul odor, drainage, fever, increasing pain, numbness, discoloration, or swelling immediately. Although these treatments may seem very different, the nursing priorities remain remarkably consistent. Whether the child has a splint, cast, traction, or surgery, nurses continually focus on maintaining circulation, preventing complications, controlling pain, protecting skin integrity, promoting mobility as appropriate, and teaching the child and family how to safely care for the injury at home. For the NCLEX-PN, remember these key concepts. Perform frequent neurovascular assessments after any orthopedic procedure or immobilization device. Compartment syndrome is an emergency. Severe pain that is disproportionate to the injury and not relieved by medication should always be reported immediately. Traction is effective only when continuous alignment is maintained and the weights hang freely. Never place objects inside a cast or allow the child to scratch beneath the cast. Splints are often used initially because they accommodate swelling better than circumferential casts. As we move through the remainder of this chapter, you'll see these treatments repeatedly because many pediatric orthopedic conditions are managed using one or more of these interventions. Understanding the purpose of each treatment and the associated nursing responsibilities will help you provide safe, evidence-based care for children with musculoskeletal disorders. Before we begin discussing fractures and other orthopedic conditions, let's review one of the most common treatments for minor musculoskeletal injuries. Many children come to the emergency department, urgent care, school nurse, or primary care office with sprains, strains, bruises, or minor soft tissue injuries. The initial management for many of these injuries follows the well-known RICE principles: rest, ice, compression, and elevation. Although the slide lists these 4 principles, I also want you to know that current sports medicine guidelines have evolved somewhat. You may hear terms such as PRICE, POLICE, or Peace and Love in current literature. However, for the NCLEX PN and most introductory nursing courses, RICE remains the standard framework you are expected to know. Let's discuss each component. The first principle is rest. After an injury, the affected body part should be protected from further stress. Continuing to run, jump, or participate in sports immediately after an injury can worsen tissue damage, increase bleeding, and prolong healing. Rest does not necessarily mean complete bed rest. Instead, it means avoiding activities that place stress on the injured area while allowing gentle movement as recommended by the healthcare provider. For children, this can be particularly challenging because they often feel better before the injury has completely healed. Nurses and parents play an important role in reinforcing activity restrictions, even when the child wants to return to normal play. The second principle is ice. Applying cold therapy helps reduce pain, swelling, inflammation, and bleeding by causing blood vessels to constrict. Ice is generally most beneficial during the first 24 to 48 hours after the injury. When using ice, remember several important safety principles. Never place ice directly on the skin because this can cause tissue damage or frostbite. Instead, wrap the ice pack in a thin towel or cloth. Ice is commonly applied for 15 to 20 minutes at a time, followed by periods without ice before repeating the treatment. Children, especially infants and younger children, have thinner skin than adults, so nurses should monitor the skin closely for excessive redness or signs of cold injury. The third principle is compression. Compression helps limit swelling by applying gentle pressure to the injured area. This is usually accomplished with an elastic bandage or compression wrap. One of the nursing priorities when applying compression is ensuring that the bandage is snug, but not too tight. A bandage that is wrapped too tightly can impair circulation and increase the risk of neurovascular compromise. After applying a compression wrap, always perform a neurovascular assessment. Check the color, temperature, capillary refill, sensation, movement, and distal pulses. If the child develops increasing pain, numbness, tingling, cool skin, or discoloration, the wrap should be loosened immediately and the healthcare provider notified if symptoms persist. The final principle is elevation. Elevating the injured extremity above the level of the heart whenever possible helps decrease swelling by promoting venous return and reducing fluid accumulation in the injured tissues. Elevation is especially helpful during the first couple of days after an injury and is often combined with ice and compression for maximum benefit. For example, a child with a sprained ankle may rest with the legs supported on pillows while an ice pack is applied. As nurses, we also remember that pain management is an important part of caring for soft tissue injuries. Depending on the severity of the injury, children may receive acetaminophen or nonsteroidal anti-inflammatory drugs such as ibuprofen, if appropriate for the child's age and medical condition. We also continue to assess for worsening pain because pain that becomes severe or disproportionate to the injury may indicate a more serious problem than a simple sprain. Now let's move into one of the most common pediatric musculoskeletal injuries, traumatic fractures. A fracture is simply a break or disruption in the continuity of a bone. In children, fractures most often occur because of falls, sports injuries, playground accidents, bicycle accidents, or motor vehicle crashes. While trauma is the most common cause, remember that fractures can occasionally occur with very little force if a child has an underlying bone disorder or disease. One of the first nursing responsibilities is recognizing the signs and symptoms of a fracture. Children typically present with pain, especially when the injured extremity is moved or touched. The child may refuse to use the affected limb or may cry when movement is attempted. Along with pain, you'll usually see tenderness, swelling, and often limited range of motion. Other findings may include bruising or discoloration, deformity if the fracture is displaced, and occasionally numbness or tingling if nearby nerves have been injured or swelling is compressing the nerves. A child may also refuse to bear weight on an injured leg or may hold an injured arm very still to avoid pain. Whenever you suspect a fracture, remember one important nursing principle. Do not attempt to straighten or realign the extremity. Instead, immobilize the injury in the position found, support the extremity, assess circulation, sensation, and movement distal to the injury, provide pain management, and prepare the child for diagnostic imaging. One of the remarkable characteristics of pediatric fractures is that they heal much faster than adult fractures. Earlier, we discussed the role of the thick periosteum, the strong outer covering of the bone. In children, this periosteum stays relatively intact during many fractures, helping hold the broken bone fragments together while also supplying an excellent blood supply for healing. Because of this, children form new callus bone much more quickly than adults and often regain function sooner. The child's periosteum is stronger and thicker, resulting in less stiffness during immobilization. This is one reason children often recover motion more rapidly after a cast is removed. Adults frequently require extensive physical therapy following prolonged immobilization, whereas many children naturally regain motion through normal play and activity once healing has occurred. Perhaps the most important point on this slide concerns the cartilaginous epiphysis, or growth plate. The growth plate is responsible for longitudinal bone growth, meaning it allows bones to become longer as children grow. Because the growth plate is made of cartilage rather than mature bone, it is actually weaker than the surrounding ligaments and tendons. If a fracture involves the growth plate, it is considered much more serious than a fracture that occurs through the shaft of the bone alone. Damage to the growth plate may cause the bone to stop growing, grow more slowly, or grow unevenly, resulting in limb length discrepancies or angular deformities. Although traction is used less frequently today than it was several decades ago because of advances in orthopedic surgery, it is still an important treatment that you may encounter in pediatric orthopedic units. As practical nurses, you need to understand why traction is used, recognize the different types, and know the nursing care required to prevent complications. Traction is the application of a continuous pulling force to an injured extremity. Its goals are to maintain proper bone alignment, reduce muscle spasms, decrease pain, prevent deformity, and allow injured tissues to heal. Traction may be used as a temporary treatment before surgery or, in some cases, as the primary treatment for certain fractures. One important concept for the NCLEX is that traction must be continuous unless a healthcare provider specifically orders it to be discontinued. If the traction force is interrupted, the muscles can spasm, bone fragments may shift, and alignment can be lost. The first type listed is Bryant traction. Bryant traction is a form of skin traction most commonly used in young children, generally those younger than 2 years of age or weighing less than about 30 pounds, 14 kilograms. It is typically used to treat femur fractures or occasionally congenital hip disorders. In Bryant traction, both legs are suspended vertically, even if only one leg is injured. The child's hips are flexed to approximately 90 degrees, with the buttocks slightly elevated off the mattress. The child's own body weight provides the countertraction. Because the legs are elevated, nurses must perform very frequent neurovascular assessments. Check skin color, warmth, pulses, capillary refill, movement, and sensation. It is also important to inspect the skin for irritation caused by the traction tape and ensure the child's buttocks remain only slightly off the mattress. If the buttocks rest completely on the bed, effective traction is lost. Regardless of which type of traction is used, the nursing priorities are very similar. First, perform frequent neurovascular assessments. Always assess pain, color, temperature, capillary refill, distal pulses, movement, sensation. Increasing pain, especially pain that is not relieved by analgesics or becomes worse with passive movement, may indicate compartment syndrome, which requires immediate intervention. Second, inspect the skin frequently. Because skin traction applies force through the skin, children are at risk for skin irritation, blisters, or pressure injuries. Keep the skin clean and dry, and inspect beneath straps and traction tape whenever appropriate. Third, maintain proper body alignment. The child's body should remain centered in bed, with the affected extremity aligned according to the orthopedic provider's instructions. Fourth, Remember that traction is continuous. Nurses should never remove or adjust the weights without a provider's order. The weights should always hang freely, and the ropes should remain in the pulleys without knots or obstructions. Finally, children in traction are often confined to bed for extended periods. This places them at risk for constipation, skin breakdown, deconditioning, and boredom. Nursing care should include encouraging age-appropriate activities, repositioning when permitted, maintaining skin integrity, promoting adequate nutrition and hydration, and supporting both the child and family emotionally. For the NCLX PN, remember these key concepts. Traction provides continuous pulling force to maintain bone alignment and reduce muscle spasms. Bryant traction is used primarily for young children with femur fractures and requires both legs to be elevated. Buck traction keeps the affected leg straight and is commonly used temporarily before surgery. Russell traction supports the knee while applying traction along the leg. Weights must hang freely and should never rest on the floor or bed. Perform frequent neurovascular assessments and monitor closely for skin breakdown and compartment syndrome. Although you may not encounter traction frequently in today's clinical settings, the nursing principles remain highly testable and reinforce important concepts you'll use whenever caring for children with orthopedic injuries. Maintaining alignment, protecting circulation, preserving skin integrity, and preventing complications. Now let's discuss one of the most common treatments you'll encounter in pediatric orthopedic nursing: casts and splints. Whether a child has a simple buckle fracture from falling off a bicycle or a more serious long bone fracture, there is a good chance they will leave the emergency department or orthopedic clinic with either a cast or a splint. Although both devices are designed to immobilize an injured extremity, there are important differences between them. A cast completely surrounds the injured body part and provides rigid support. A splint, sometimes called a half cast, supports only part of the extremity and is secured with elastic bandages or straps. Because splints leave room for swelling, they are often used immediately after an injury, while casts are frequently applied after the initial swelling has decreased. The slide mentions that casts and splints can be made from a variety of materials. The two most common cast materials are plaster and fiberglass. Plaster casts are heavier and take longer to dry, sometimes 24 to 72 hours depending on their thickness. However, they mold extremely well to the shape of the injured extremity, making them useful for certain fractures. Fiberglass casts are lighter, stronger, more durable, and dry much faster, usually within 20 to 30 minutes. They are also more resistant to water, although the padding underneath often still needs to stay dry unless the child has a special waterproof liner. Regardless of the material used, our nursing care focuses on preventing complications. The first major complication listed is impaired skin integrity. Children are especially vulnerable to skin problems because they often have difficulty communicating discomfort and may become tempted to insert objects inside the cast when itching develops. One of the most important teaching points for families is that nothing should ever be inserted inside a cast. Although children often want to use pencils, rulers, coat hangers, or other objects to scratch an itch, doing so can create skin tears, pressure injuries, or infections that cannot easily be seen beneath the cast. Instead, families can try using cool air from a hairdryer on the cool setting, gently tapping the outside of the cast, or distracting the child with activities until the itching subsides. The cast should also be kept clean and dry. Wet padding can lead to skin maceration, unpleasant odor, and infection. If the cast becomes soaked, the family should contact the orthopedic provider for further instructions. The second major complication, and the one you absolutely must recognize for the NCLEX, is compartment syndrome. Compartment syndrome occurs when pressure builds inside a closed muscle compartment, usually because of swelling after an injury. Since the muscles are surrounded by tough connective tissue called fascia, there is very little room for expansion. As swelling increases, the pressure compresses blood vessels and nerves, reducing circulation to the muscles and surrounding tissues. The slide describes this as progressive loss of tissue perfusion, which is exactly what happens. If circulation is not restored quickly, the affected tissues begin to die. This is considered an orthopedic emergency. The earliest and most reliable sign of compartment syndrome is pain that is severe and out of proportion to the injury. Children may complain that the pain continues to worsen even after receiving pain medication. They may also experience increasing pain when the fingers or toes are passively stretched. As pressure continues to rise, other neurovascular changes develop. Assess and compare color temperature, capillary refill, distal pulses, movement, sensation, pain level. Always compare the injured extremity with the unaffected side whenever possible. If compartment syndrome is suspected, notify the healthcare provider immediately. Delayed treatment can result in permanent nerve damage, muscle necrosis, loss of function, and in severe cases, amputation. The definitive treatment is often an emergency surgical procedure called a fasciotomy, in which the fascia is surgically opened to relieve pressure and restore circulation. When teaching families before discharge, review these important home care instructions. Keep the cast clean and dry. Do not place objects inside the cast. Elevate the extremity during the first 24 to 48 hours to reduce swelling. Encourage the child to gently move the fingers or toes, unless instructed otherwise. Report immediately, increasing pain not relieved by medication, numbness or tingling blue, pale, or cold, fingers or toes increasing swelling, inability to move the fingers or toes, drainage, foul odor, fever, or soft spots in the cast. Now, let's discuss osteomyelitis, one of the most important musculoskeletal infections you will encounter in pediatric nursing. Unlike a fracture, which results from trauma, osteomyelitis is an infection of the bone. Although it is relatively uncommon, it is considered a medical emergency because delayed treatment can lead to permanent bone damage, growth abnormalities, chronic infection, or even sepsis. The slide notes that osteomyelitis most commonly occurs in infants younger than 1 year of age and in school-age children between 5 and 14 years old. These age groups are more susceptible because of the unique blood supply to their growing bones. Most cases of osteomyelitis develop through hematogenous spread, meaning bacteria travel through the bloodstream from another site in the body and become lodged in the bone. Children may have recently experienced something as simple as an upper respiratory infection, otitis media, or a skin infection before developing osteomyelitis. The most common causative organism is Staphylococcus aureus, including methicillin-resistant Staphylococcus aureus, MRSA in some cases. Depending on the child's age and medical history, other bacteria may also be responsible, but if you're asked on the NCLX which organism most commonly causes osteomyelitis, the answer is Staphylococcus aureus. Because children have a rich blood supply near the growth plates, bacteria commonly become trapped in the metaphysis of long bones. As the infection progresses, inflammation develops inside the bone, swelling increases pressure within the bone, reducing blood flow and causing significant pain. Without treatment, portions of the bone may lose their blood supply and begin to die, making the infection much more difficult to eradicate. Children with osteomyelitis often present with symptoms that can initially resemble a fracture or joint injury. They commonly have localized bone pain, tenderness, swelling, warmth over the affected area. Limited movement or refusal to use the extremity, limping or refusal to bear weight if the leg is involved, fever, general irritability or malaise. One of the biggest clinical clues is that the child refuses to move the affected extremity because movement is extremely painful. Infants may simply become irritable whenever the extremity is touched or moved. Diagnosis combines the physical examination with several diagnostic studies. Laboratory findings often include elevated white blood cell count, increased erythrocyte sedimentation rate, ESR, elevated C-reactive protein, CRP. Blood cultures are frequently obtained before antibiotics are started, so the causative organism can be identified. Imaging studies may include X-rays, although they are often normal early in the disease. MRI, which is considered the most sensitive imaging study for detecting early osteomyelitis. Occasionally a bone scan if MRI is unavailable. Sometimes a bone biopsy or aspiration, which allows identification of the specific bacteria and guides antibiotic therapy. Treatment should begin as quickly as possible. Children are usually admitted to the hospital and started on intravenous antibiotics, often before the exact organism is identified. As nurses, we also monitor the child's response to treatment by assessing pain level, temperature, swelling, ability to move the extremity, laboratory values such as ESR, CRP, and white blood cell count. Improvement in these findings generally indicates that treatment is working. Family education is also essential. Parents should understand the importance of completing the entire course of antibiotics, even if the child begins feeling much better. Stopping antibiotics early increases the risk of recurrence or chronic infection. For the NCLX-PN, remember these key concepts. Osteomyelitis is an infection of the bone and is a medical emergency requiring prompt treatment. The most common causative organism is Staphylococcus aureus. Children commonly present with fever, bone pain, swelling, tenderness, and refusal to use the affected extremity. MRI is the most sensitive imaging study for early osteomyelitis. ESR and CRP are usually elevated because they are markers of inflammation. Treatment includes prolonged intravenous antibiotics and sometimes surgical debridement. Untreated osteomyelitis can damage the growth plate, resulting in impaired bone growth and permanent deformity. One final clinical pearl: if a child has fever, refuses to bear weight, and has severe bone pain without a history of trauma, always think about osteomyelitis as a possible diagnosis. Early recognition and treatment can prevent lifelong complications and preserve normal bone growth. Muscular dystrophy is a group of disorders characterized by progressive muscle degeneration. There are several different forms of muscular dystrophy, but Duchenne muscular dystrophy is the most common and the most severe form seen in childhood. Duchenne muscular dystrophy is an X-linked recessive genetic disorder, meaning the abnormal gene is located on the X chromosome. Because boys have only one X chromosome, they are almost always the ones affected. The disorder is caused by the absence or severe deficiency of a protein called dystrophin. Dystrophin helps stabilize muscle cell membranes during muscle contraction. Without enough dystrophin, muscle fibers become damaged every time they contract. Over time, healthy muscle tissue is gradually destroyed and replaced with fat and connective tissue, leading to progressive muscle weakness. Symptoms generally begin between 2 and 6 years of age, although subtle developmental delays may appear even earlier. Parents often report that their child was late to crawl, walk, run, or climb stairs compared with other children. One of the earliest signs is delayed motor development. These children may seem clumsy, fall frequently, have difficulty running, or tire easily during play. Parents sometimes describe them as always the last one to keep up with other children. One classic finding you'll almost certainly see on the NCLEX is the Gowers sign. When a child with Duchenne muscular dystrophy attempts to stand from the floor, they cannot simply stand upright because their hip and thigh muscles are too weak. Instead, they first get onto their hands and knees and then use their hands to walk up their own legs, pushing on their thighs until they are able to stand. If you ever see a question describing a child climbing up their own legs to stand, immediately think Duchenne muscular dystrophy. Another hallmark finding is pseudo-hypertrophy of the calves. Although the calf muscles appear large and well-developed, they are actually becoming enlarged because fat and connective tissue are replacing normal muscle, not because the muscles are getting stronger. In fact, despite their appearance, these muscles are becoming progressively weaker. As the disease advances, children gradually lose the ability to walk. Most children require a wheelchair by approximately 10 to 12 years of age, although improved treatments have helped many children remain ambulatory somewhat longer than in the past. Today, the diagnosis is usually confirmed with genetic testing, which identifies mutations in the dystrophin gene. Although there is no cure for Duchenne muscular dystrophy, treatment has improved significantly over the past 2 decades. Management focuses on corticosteroids such as prednisone or deflazacort to slow muscle deterioration, physical therapy to preserve mobility and prevent contractures, occupational therapy to maintain independence, respiratory support, including cough assist devices, and eventually ventilatory support if needed, cardiac monitoring and treatment, nutritional support, and psychosocial support for both the child and family. As nurses, our role extends far beyond physical care. This is a progressive, life-limiting illness that affects the entire family. We provide education, encourage independence whenever possible, prevent complications such as skin breakdown and respiratory infections, support mobility, and help families access community resources. For the NCLX-PN, remember these key concepts. Duchenne muscular dystrophy is an X-linked recessive disorder that primarily affects boys. It results from the absence of dystrophin, leading to progressive muscle degeneration. Symptoms usually begin between 2 and 6 years of age with delayed motor development and frequent falls. The Gowers sign is a classic finding. Calf pseudohypertrophy results from fat replacing muscle tissue. Creatine kinase, CK or CPK levels are markedly elevated early in the disease. Genetic testing is now the primary diagnostic test. Respiratory muscle weakness and cardiomyopathy are major causes of morbidity and mortality later in the disease. One final teaching point for students. Duchenne muscular dystrophy is not a disease of the nerves or bones. It is a disease of the muscles. Understanding that distinction helps explain why these children gradually lose strength, even though their sensation and cognitive abilities are often relatively preserved. As the disease progresses, the nursing focus shifts from curing the disease, which is not currently possible, to maximizing function, preserving quality of life, and supporting both the child and family throughout the disease course. So, what exactly is SCFE? Think back to our discussion about the growth plate or epiphysis. During adolescence, the growth plate is still made of cartilage, making it the weakest part of the bone. In SCFE, the head of the femur stays in the hip socket, while the neck and shaft of the femur gradually slip forward and upward beneath the growth plate. A simple way to picture this is to imagine a scoop of ice cream sliding off an ice cream cone. The scoop stays in place, but the cone moves. That is the classic analogy used to describe SCFA. Unlike fractures, SCFA usually does not result from a major injury. Instead, it develops gradually during periods of rapid growth, especially during early adolescence. The condition most commonly occurs in children between approximately 10 and 16 years of age, and is seen more frequently in boys than girls. One of the biggest risk factors is obesity. Extra body weight places increased stress across the growth plate of the hip. Other risk factors include rapid growth during puberty and certain endocrine disorders such as hypothyroidism, growth hormone abnormalities, or renal osteodystrophy. The slide correctly notes that SCFE is generally not related to trauma. Parents often report there was no significant injury, although occasionally a minor fall brings attention to symptoms that were already developing. One interesting feature of SCFE is that children often complain of knee pain instead of hip pain. This occurs because the nerves supplying the hip also supply the knee, a phenomenon known as referred pain. This is an important NCLEX concept. Whenever you have an adolescent with persistent knee pain but a normal knee examination, you should think about examining the hip. The most common symptoms include hip pain, groin pain, thigh pain, referred knee pain, limping, difficulty walking, limited range of motion, in more severe cases, inability to bear weight. As the disease progresses, the affected leg often rests in external rotation, meaning the foot points outward. Diagnosis is usually confirmed with X-rays of both hips. Because SCFA may occur on both sides, providers generally image both hips, even if symptoms are present on only one side. Once SCFA is diagnosed, weight bearing should stop immediately. Continuing to walk can cause further slippage of the growth plate and increase the risk of serious complications. The slide mentions that buck extension traction may be used temporarily before surgery. While this has been described historically, I want to update this with current practice. Today, buck traction is used much less frequently. The standard treatment is in situ pinning, where one or more screws are inserted across the growth plate to prevent additional slipping. Importantly, the surgeon does not attempt to force the growth plate back into place, because doing so increases the risk of damaging the blood supply to the femoral head. One of the most serious complications of SCFE is avascular necrosis, sometimes called osteonecrosis. Remember, avascular means without blood supply. If the blood vessels supplying the femoral head become damaged, the bone tissue begins to die because it no longer receives oxygen and nutrients. This can eventually lead to collapse of the femoral head and severe arthritis later in life. Another complication is chondrolysis, which involves destruction of the articular cartilage within the hip joint, resulting in stiffness and chronic pain. From a nursing perspective, priorities include maintaining non-weight-bearing status until surgery, managing pain, monitoring neurovascular status, preparing the child and family for surgery, providing emotional support since adolescents may become frustrated by sudden restrictions on activity, teaching the family the importance of following post-operative weight-bearing restrictions and attending follow-up appointments. After surgery, physical therapy helps gradually restore mobility while protecting the repaired hip. For the NCLEX PN, remember these key concepts. SCFE occurs during periods of rapid adolescent growth. Obesity is the biggest risk factor. Many children present with knee pain rather than hip pain because of referred pain. The child typically has a limp and decreased hip range of motion with the leg externally rotated. Immediately stop weight bearing once SCFE is suspected. Treatment is prompt surgical stabilization with pinning. The most serious complication is avascular necrosis of the femoral head. One final clinical pearl: whenever an overweight adolescent presents with limping, persistent knee pain or hip pain without a clear injury, always think about slipped femoral capital epiphysis. Recognizing this condition early and preventing further weight bearing can significantly improve the child's long-term outcome and reduce the risk of permanent hip damage. The next condition we'll discuss is Legg-Calvé-Perthes disease, often simply called Perthes disease. Like slipped femoral capital epiphysis, this condition affects the hip, but the cause, age group, and treatment are quite different. It is important to understand these differences because both conditions commonly appear on the NCLEX and in pediatric practice. Legg-Calvé-Perthes Perthes disease is an idiopathic avascular necrosis of the femoral head. Let's break that down. Idiopathic means we do not know the exact cause. Avascular means without blood supply. Necrosis means tissue death. So in Perthes disease, the blood supply to the head of the femur is temporarily interrupted. Without an adequate blood supply, the bone tissue begins to die. Over time, the body gradually removes the dead bone and replaces it with new bone. This healing process can take 2 to 4 years, which is why this condition requires long-term follow-up. The slide mentions that Perthes disease belongs to a group of disorders called osteochondroses. These are disorders in which the blood supply to growing bone is disrupted, affecting normal bone development. Because the femoral head forms the ball portion of the hip joint, interruption of its blood supply affects both the shape and strength of the hip. If the femoral head heals in an abnormal shape, the child may develop chronic pain, decreased range of motion, or early arthritis later in adulthood. One important concept is avascular necrosis. Unlike SCFE, obesity is not considered a major risk factor. Children usually present gradually rather than suddenly. Parents often notice a painless or mildly painful limp, hip pain, groin pain, thigh pain, referred knee pain, decreased activity, stiffness after periods of rest. Again, notice that referred knee pain appears here just like it did with SCFA. Whenever a child has persistent knee pain with no obvious knee injury, always remember to consider hip pathology. As the disease progresses, the child develops limited hip range of motion, especially abduction and internal rotation. Unlike an acute fracture, these children generally do not appear severely ill. Symptoms usually develop gradually over weeks or months. Diagnosis begins with a physical examination and x-rays of the pelvis and hips. However, early x-rays may appear normal because the changes take time to develop. If Perthes disease is suspected, but x-rays are inconclusive, providers may order an MRI, which can identify changes much earlier than plain radiographs. Treatment depends largely on the child's age, the severity of femoral head involvement, the stage of the disease. The overall goal is simple. Keep the femoral head as round as possible while it heals. If the ball remains round, it fits better into the hip socket and functions much more normally throughout life. Treatment may include activity restriction, limited weight-bearing physical therapy, range of motion exercises, anti-inflammatory medications, bracing or casting to maintain proper hip alignment. Occasionally surgery in more severe cases. Unlike SCFE, where urgent surgery is usually required, Perthes disease is often managed conservatively, especially in younger children. From a nursing perspective, priorities include managing pain, encouraging adherence to activity restrictions, supporting physical therapy, participation, monitoring mobility, teaching families that healing requires patience because recovery occurs over years, not weeks. Family education is essential. Parents should understand that even though symptoms may improve before the bone has completely healed, the child must continue following the orthopedic treatment plan to minimize long-term deformity. Marked distortion of the femoral head may occur. This happens because as the dead bone is removed and replaced, the femoral head may become flattened or irregular instead of remaining perfectly round. If significant deformity develops, the child is at greater risk for hip stiffness, chronic pain, leg length discrepancy. Early degenerative arthritis as an adult SCFE affects older adolescents, usually during puberty, and results from slipping of the growth plate. For the NCLEX-PN, remember these key concepts. Leg-calf Perthes disease is idiopathic avascular necrosis of the femoral head. It is most common in boys between approximately 5 and 12 years of age. Children usually present with a gradual limp, hip pain, or referred knee pain. MRI may detect disease earlier than X-ray. Treatment focuses on preserving the shape of the femoral head while healing occurs over 2 to 4 years. Unlike SCFE, treatment is often conservative rather than immediately surgical. The long-term concern is permanent deformity of the femoral head and early arthritis if healing is incomplete. The prefix osteo refers to bone, and sarcoma refers to a malignant tumor that develops from connective tissue. Therefore, osteosarcoma is a cancer that originates from bone-forming cells called osteoblasts. Unlike cancers that spread to the bone from another location, osteosarcoma begins in the bone itself, which is why it is called a primary malignant bone tumor. The slide notes that the average age at diagnosis is between 10 and 15 years, and this is not a coincidence. Osteosarcoma most commonly develops during adolescent growth spurts, when bones are growing rapidly. The tumor usually develops in the metaphysis of long bones, especially around the knee. The most common locations include the distal femur, just above the knee, the proximal tibia just below the knee, the proximal humerus near the shoulder. A simple way to remember this is that osteosarcoma tends to occur around the knee. The exact cause is usually unknown, but certain children have a higher risk. The slide correctly states that children who previously received radiation therapy for another cancer have an increased risk. One of the biggest clinical challenges is that osteosarcoma often begins with symptoms that resemble a sports injury. Children commonly report persistent bone pain, localized tenderness, swelling, limping, decreased range of motion if the tumor is near a joint. Unlike an acute injury, however, the pain does not improve with rest. In fact, one classic NCLEX clue is that the pain is often worse at night and gradually becomes more severe over weeks or months. Parents sometimes report that the child was treated repeatedly for a pulled muscle or sports injury, but the pain continued to worsen. As the tumor enlarges, swelling becomes more noticeable and the affected bone becomes weaker. Biopsy, which confirms the diagnosis and determines the specific tumor type. Metastasis occurs quickly because bone is highly vascular. This is an important concept. Years ago, treatment often required amputation, but advances in orthopedic oncology now allow many children to undergo limb salvage surgery, in which the tumor is removed and the affected bone is reconstructed using metal prostheses or bone grafts. Depending on the location and size of the tumor, however, amputation may still be necessary in some cases to completely remove the cancer. After surgery, additional chemotherapy is usually administered to reduce the risk of recurrence. Unlike many other cancers, radiation therapy is generally not very effective for osteosarcoma, so surgery and chemotherapy remain the primary treatments. From a nursing perspective, and caring for children with osteosarcoma involves much more than treating the tumor. Nursing priorities include managing pain, monitoring for chemotherapy side effects such as neutropenia, infection, anemia, nausea, and fatigue, providing post-operative care after limb salvage surgery or amputation. Monitoring neurovascular status following orthopedic surgery, promoting mobility through physical therapy, supporting body image and emotional adjustment, particularly if amputation is required, educating families about chemotherapy precautions, infection prevention, and follow-up care. For adolescents, the diagnosis can be emotionally devastating because it often occurs during a period when body image, independence, and peer relationships are especially important. Psychosocial support for both the child and family is therefore an essential part of nursing care. For the NCLEX PN, remember these key concepts. Osteosarcoma is the most common primary malignant bone tumor in children and adolescents. It most commonly develops during periods of rapid adolescent growth. The distal femur and proximal tibia around the knee are the most common locations. Persistent bone pain, especially pain that worsens at night and does not improve with rest, is a classic finding. Children are at risk for pathologic fractures because the tumor weakens the bone. The lungs are the most common site of metastasis. Treatment usually includes chemotherapy, followed by limb salvage surgery or, in some cases, amputation. One final teaching point that helps distinguish this condition from many orthopedic injuries. Sports injuries gradually improve with time, while osteosarcoma pain progressively worsens. If an adolescent has persistent bone pain, swelling, or limping that does not resolve with conservative treatment, further evaluation is essential. Early diagnosis greatly improves the likelihood of successful treatment and long-term survival. JIA is the most common chronic rheumatologic disease of childhood and the most common form of arthritis in children. Unlike osteoarthritis in older adults, which results from years of wear and tear, JIA is an inflammatory disease. The immune system attacks the synovium, which is the lining of the joints. This causes inflammation, swelling, pain, and stiffness. If the inflammation continues over time, it can damage cartilage, bone, and even interfere with normal bone growth. The slide mentions that JIA is a systemic inflammatory disease involving the joints, connective tissues, and viscera. The term viscera simply refers to the internal organs. Although many children have disease limited to the joints, some forms of JIA can also affect the eyes, heart, lungs, liver, spleen, lymph nodes. This is why JIA is considered a systemic autoimmune disease, not simply a joint disorder. One important concept on this slide is that there is no single diagnostic test for JIA. Unlike some diseases where one laboratory test confirms the diagnosis, JIA is diagnosed by combining the child's history, physical examination, duration of symptoms, laboratory studies imaging, excluding other possible causes. This is why the slide emphasizes that symptoms should last longer than 6 weeks. However, it's important to remember that many children with JIA have normal laboratory results, especially early in the disease. This is another reason diagnosis depends on the overall clinical picture rather than one specific laboratory value. Torticollis, commonly called wry neck. Torticollis is not a disease of the bones or joints, but rather a condition involving the muscles of the neck, specifically the sternocleidomastoid muscle, often abbreviated SCM. The sternocleidomastoid muscle is a large muscle that runs from the sternum and clavicle to the mastoid process behind the ear. Normally, this muscle helps us turn our head from side to side and flex the neck. In torticollis, one sternocleidomastoid muscle becomes shortened or tight, preventing normal neck movement. As a result, the child's head tilts toward the affected side, while the chin rotates toward the opposite side. For example, if the right sternocleidomastoid muscle is shortened, the child's head tilts to the right, and the chin points towards the left. This is a classic NCLEX concept. The slide notes that torticollis may be congenital or acquired. Congenital muscular torticollis is by far the most common form and is usually recognized during infancy. The exact cause is not always known, but it is thought to result from injury or prolonged positioning of the sternocleidomastoid muscle before or during birth. Several birth factors increase the risk, including breech presentation, difficult deliveries, forceps-assisted delivery, limited space in the uterus, particularly with multiple gestation. The muscle may develop fibrosis, causing permanent shortening if left untreated. The slide also mentions that torticollis may occur along with developmental dysplasia of the hip, or DDH. This is an important association. Because both conditions may result from abnormal fetal positioning, any infant diagnosed with congenital torticollis should also be carefully evaluated for hip dysplasia. As nurses, this reminds us that when one congenital musculoskeletal abnormality is present, we should always assess for others that commonly occur together. The slide also mentions that torticollis may be acute or chronic. Congenital torticollis is typically chronic until treated. Acquired torticollis, however, can occur later in childhood and may result from muscle strain, enlarged cervical lymph nodes, upper respiratory infections, trauma, inflammation, certain medications causing muscle spasms, cervical spine abnormalities. Unlike congenital torticollis, acquired torticollis often develops suddenly and may be painful. During assessment, several findings are common. The infant or child may have a persistent head tilt, limited neck range of motion, difficulty turning the head equally in both directions, a firm lump or thickening within the sternocleidomastoid muscle in some infants, facial asymmetry if treatment is delayed. Infants may also consistently prefer looking in one direction. This becomes important because persistent positioning can lead to positional plagiocephaly, or flattening of one side of the skull. Diagnosis is usually based on the physical examination. Depending on the child's age and symptoms, providers may order ultrasound of the sternocleidomastoid muscle, cervical spine x-rays, imaging of the hips if developmental dysplasia is suspected. Treatment should begin as early as possible because younger infants respond extremely well. The primary treatment is physical therapy. Parents are taught gentle stretching exercises several times each day to gradually lengthen the shortened muscle. Therapy also includes encouraging tummy time while awake, positioning toys on the affected side to encourage the infant to turn the head, alternating feeding positions, frequently changing the infant's position in the crib. These simple interventions encourage equal neck movement while preventing flattening of the skull. From a nursing perspective, one of our biggest responsibilities is parent education. Parents should understand that stretching exercises must be performed consistently. Improvement occurs gradually over weeks to months. Early treatment usually results in excellent outcomes. Follow-up appointments are important to monitor progress. Families often worry they are hurting their baby during stretching exercises, so demonstrating proper technique and reassuring them is extremely valuable. Scoliosis, one of the most common spinal disorders seen in children and adolescents. Scoliosis is defined as a lateral or sideways curvature of the spine, measuring greater than 10 degrees, and it is usually accompanied by rotation of the vertebrae. This rotation is what makes scoliosis much more than simply poor posture. The first type listed is functional scoliosis. Functional scoliosis means the spine itself is structurally normal, but something else is causing the curve. Examples include poor posture, muscle spasm, one leg being shorter than the other, pain causing the child to lean to one side. Because the spine is structurally normal, functional scoliosis usually resolves when the underlying problem is corrected. The second type is structural scoliosis. This is the type most often discussed in pediatrics. With structural scoliosis, the vertebrae themselves are rotated and permanently curved. The curve cannot simply be corrected by asking the child to stand up straight. The most common form is actually adolescent idiopathic scoliosis, meaning we do not know exactly why it develops. This accounts for approximately 80% of scoliosis cases. For the NCLX-PN, remember these key concepts. Scoliosis is a lateral curvature of the spine accompanied by vertebral rotation. Adolescent idiopathic scoliosis is the most common type. Progressive scoliosis is more common in girls. Uneven shoulders, uneven hips, and a rib hump are common assessment findings. The Adams Forward Bend test is the primary screening examination. Braces prevent progression of the curve. They do not straighten the spine. Bracing is most effective while the child is still growing. Severe curves may require spinal fusion surgery. One final teaching point that helps tie together many of the musculoskeletal conditions we've discussed in this chapter. Children are constantly growing, so disorders involving growth plates, bones, joints, and the spine must be recognized and treated early. Early intervention often prevents lifelong disability and allows children to achieve the best possible function as they continue to grow and develop. Sports injuries are very common in school-aged children and adolescents. Before participating in school sports, most students complete a pre-participation sports physical to identify medical conditions that could increase the risk of injury or complications during athletic activities. Some of the most common sports injuries include concussions, stingers or burners, knee injuries, ankle sprains, muscle cramps, and shin splints. As nurses, our priorities are to recognize injuries early, remove the athlete from play when appropriate, provide initial treatment, and refer for further evaluation when necessary. One injury that always requires immediate attention is a concussion. Remember the phrase, "When in doubt, sit them out." A child with a suspected concussion should never return to play the same day until evaluated and medically cleared. For most sprains, strains, and overuse injuries, initial treatment follows the RICE principles: rest, ice, compression, and elevation, along with pain management and gradual return to activity as symptoms improve. For the NCLX-PN, remember these key points. Sports physicals help identify conditions that may increase the risk of injury. A suspected concussion requires immediate removal from play and medical evaluation. RICE is the initial treatment for many minor musculoskeletal injuries. Prevention includes proper conditioning, stretching, hydration, protective equipment, and safe athletic techniques. Now let's turn our attention to child abuse and family violence, because musculoskeletal injuries are sometimes the first sign of abuse. As nurses, we are mandated reporters, meaning we are legally required to report suspected child abuse or neglect. It is not our job to investigate or prove abuse. Our responsibility is to recognize concerning findings, document them objectively, and report our concerns according to state law and facility policy. Child abuse can take many forms, including physical abuse, sexual abuse, emotional abuse, and neglect, which may be physical or emotional. Family violence affects children of all ages, backgrounds, cultures, and socioeconomic groups. Abuse is never limited to one type of family or community. Be alert for injuries that do not match the explanation provided. Multiple injuries in different stages of healing, delays in seeking medical care, patterned bruising or burns, or changing stories from caregivers. Behavioral changes such as fearfulness, withdrawal, aggression, or excessive compliance may also raise concern. When abuse is suspected, carefully document objective findings rather than personal opinions. Describe exactly what you see and hear, including the size, location, color, and appearance of injuries and statements made by the child or caregiver. For the NCLX-PN, remember these key points. LPNs are mandated reporters of suspected child abuse and neglect. Document objective observations rather than opinions. Report suspected abuse promptly according to state law and facility policy. The nurse's role is to recognize, document, protect the child, and report, not to investigate or determine guilt. When child abuse or neglect is suspected, nurses have both an ethical and legal responsibility to act. Every state has mandatory reporting laws that require certain professionals, including nurses, to report suspected child abuse or neglect. While the specific reporting process varies by state, the overall responsibility is the same. Notice that the slide says suspected abuse or neglect. This is an important distinction. Nurses do not need proof that abuse occurred before making a report. If there is reasonable suspicion based on assessment findings, statements, or observations, a report should be made according to state law and facility policy. The slide also points out that individuals who report suspected abuse in good faith are protected from criminal prosecution and civil liability. In other words, if you make a report honestly because you believe a child may be at risk, the law provides legal protection, even if the investigation later determines that abuse did not occur. After making a report, the nurse should continue providing safe, compassionate care to both the child and family. It is important to remain professional, avoid accusations or confrontation, and allow Child Protective Services and law enforcement to conduct the investigation. Finally, every nurse should know the mandatory reporting requirements in the state where they practice. As future LPNs in Ohio, you will be expected to follow Ohio's mandatory reporting laws, your employer's policies, and the chain of command when reporting suspected abuse. For the NCLX-PN, remember these key points. Report suspected abuse. You do not need proof. Good faith reporters are protected from civil and criminal liability. Document objective findings carefully and accurately. The nurse's responsibility is to assess, document, report, and protect the child, not to investigate the allegation. Once a child's immediate safety has been addressed, nursing care focuses on supporting recovery and promoting resilience. Children who have experienced abuse or neglect often struggle with anxiety, low self-esteem, difficulty trusting others, and problems expressing their emotions. One important nursing intervention is teaching anxiety-reducing techniques. Depending on the child's age, these may include deep breathing, relaxation exercises, guided imagery, or other healthy coping strategies to help manage stress. Children should also be encouraged to develop assertiveness skills. This means learning how to communicate their feelings, set appropriate boundaries, and seek help from a trusted adult when they feel unsafe. Teaching children that it is okay to say no to inappropriate behavior and to tell a trusted adult is an important part of abuse prevention. Another goal is to strengthen healthy coping mechanisms. Nurses can encourage activities that build confidence, provide emotional support, and help children develop positive ways to handle difficult situations. The slide also emphasizes helping children manage their feelings. Many abused children experience fear, guilt, anger, sadness, or shame. Providing a safe, non-judgmental environment allows them to express these emotions while working with mental health professionals when appropriate. Developing problem-solving skills helps children learn healthy ways to respond to challenges and make safe decisions. Age-appropriate education and positive reinforcement can improve confidence and independence. Finally, values clarification helps children develop healthy relationships, recognize appropriate behaviors, and build a positive sense of self. For the NCLX-PN, remember these key points. Ensure the child's immediate safety first. Provide emotional support in a calm, non-judgmental environment. Teach healthy coping, communication, and assertiveness skills. Collaborate with social workers, counselors, Child Protective Services, and the interdisciplinary team to support the child's long-term recovery. When assessing a child for possible abuse or neglect, nurses must provide culturally sensitive, unbiased care. Understanding a family's cultural beliefs and health practices helps us provide respectful care while ensuring the child's safety. Some traditional healing practices may leave marks that could be mistaken for abuse if the nurse is unfamiliar with them. Examples include cupping, coining, or certain herbal remedies. Rather than making assumptions, ask respectful, open-ended questions to understand the family's practices, while carefully assessing whether the child's injuries are consistent with the explanation provided. At the same time, cultural practices do not excuse child abuse or neglect. If there is reasonable suspicion that a child has been harmed or is at risk, the nurse must follow mandatory reporting laws regardless of cultural background. Accurate documentation is essential. Record objective findings such as the location, size, color, and appearance of injuries. Document the child's statements and the caregiver's statements using direct quotes whenever possible, as well as any observed interactions between the child and caregiver. Avoid personal opinions or conclusions in the medical record. If abuse is suspected, Child Protective Services, CPS, or the appropriate child welfare agency is responsible for conducting the investigation. The nurse's role is to assess, document, report, and continue providing safe, compassionate care while cooperating with the investigative team. For the NCLEX PN, remember these key points. Provide culturally sensitive, non-judgmental care. Do not confuse traditional healing practices with abuse without a thorough assessment. Document objective findings and direct quotes accurately. Report suspected abuse and allow Child Protective Services to conduct the investigation. Now let's shift our focus to skin conditions in children. The skin is the body's largest organ and serves as the first line of defense against injury, infection, and fluid loss. Because children's skin is thinner and more delicate than an adult's, they are often more susceptible to irritation, infection, and dehydration when skin disorders occur. Throughout this section, we'll discuss some of the most common pediatric skin conditions, including infectious diseases, inflammatory disorders, infestations, and allergic reactions. As nurses, it is important to recognize the appearance of these conditions, understand how they spread, identify appropriate treatments, and know when isolation or additional precautions are needed. Many childhood skin disorders are self-limiting, but others require prompt recognition to prevent complications or transmission to others. Assessment should always include the appearance, location, distribution, color, size, and drainage of skin lesions, along with associated symptoms such as itching, pain, fever, or signs of infection. For the NCLEX PN, remember these general principles as you study pediatric skin disorders. Children have thinner, more fragile skin than adults. Carefully assess the characteristics and distribution of skin lesions. Determine whether the condition is infectious, inflammatory, allergic, or traumatic. Provide appropriate skincare, prevent secondary infection, and educate families about treatment and prevention. This chapter focuses on the assessment, recognition, and nursing management of common pediatric skin conditions. As nurses, you'll need to distinguish between conditions that are normal and self-limiting, those that require treatment, and those that require prompt intervention to prevent complications or transmission to others. By the end of this chapter, you should be able to recognize the differences between infant and adult skin, identify common congenital skin lesions and infections, and understand the nursing care for bacterial, viral, fungal, parasitic, inflammatory, and allergic skin disorders. We'll also discuss common conditions such as acne, eczema, pediculosis, scabies, and different causes of hair loss. You'll learn the principles of topical therapy, including selecting the appropriate medication and teaching families how to apply treatments correctly. Finally, we'll spend time discussing burns, including burn classification, emergency treatment, nursing priorities, and how the response to burns differs in children compared with adults. We'll also cover the prevention and management of sunburn and frostbite. As you move through this chapter, focus on 3 recurring questions. What does this skin condition look like? How is it treated and what nursing care is required? Is it contagious and what teaching should be provided to the child and family? Keeping those questions in mind will help organize the material and prepare you for both clinical practice and the NCLEX PN. Before discussing specific skin disorders, it's important to review the normal functions of the skin. Understanding what healthy skin does helps explain why children can become seriously ill when the skin is damaged by infection, burns, or other conditions. The skin's primary function is protection. It serves as the body's first line of defense against bacteria, viruses, fungi, and other microorganisms that could cause infection. The skin also acts as a physical barrier, protecting the body from harmful chemicals, irritants, ultraviolet radiation, and minor injuries. When this barrier is disrupted, pathogens can enter more easily, increasing the risk of infection. Another essential function is preventing the loss of water and electrolytes. Healthy skin helps maintain fluid balance by keeping moisture inside the body. This is especially important in infants and young children because they have a larger body surface area relative to their weight and are more likely to become dehydrated when large areas of skin are damaged. Fortunately, the skin has an excellent ability to regenerate and repair itself. New skin cells are continuously produced, allowing minor cuts, abrasions, and superficial injuries to heal. However, deeper injuries, such as full-thickness burns, may require more extensive treatment because the skin's ability to regenerate is limited. Although not listed on this slide, remember that the skin also helps regulate body temperature, provides sensory perception through nerve endings, and participates in vitamin D synthesis, all of which contribute to maintaining overall health. For the NCLEX PN, remember these key functions of the skin: protects the body from infection and injury, acts as a barrier against harmful physical and chemical agents, prevents excessive loss of water and electrolytes, has the ability to regenerate and repair itself after minor injury, also contributes to temperature regulation, sensation, and vitamin D production. When assessing a child, remember that the skin often provides important clues about the child's overall health. Some skin conditions are primary disorders of the skin, while others are actually signs of an underlying systemic disease. For example, a rash may be the first indication of a viral illness, an autoimmune disorder, or even a nutritional deficiency. The slide also points out that some skin conditions are congenital, meaning they are present at birth. Many congenital skin findings are completely benign, while others may require further evaluation or monitoring. One of the most important parts of the skin assessment is evaluating skin color. Changes in color can provide valuable diagnostic information. For example, pallor may suggest anemia or poor perfusion. Cyanosis may indicate inadequate oxygenation. Jaundice suggests elevated bilirubin levels. Erythema or redness often indicates inflammation or infection. When assessing children with darker skin tones, remember that these color changes may be easier to identify in the lips, oral mucosa, nail beds, palms, and soles rather than on the skin alone. The slide also mentions skin testing for allergies. Allergy skin tests help identify substances that trigger allergic reactions by observing the skin's response to small amounts of specific allergens. These tests should always be interpreted in conjunction with the child's history and symptoms. Assessment should also include the hair. Healthy hair should have an even distribution, normal texture, appropriate elasticity, and a healthy appearance. Changes in the hair may reflect an underlying health problem. For example, poor nutrition may cause hair to become dry, brittle, or sparse. Endocrine disorders and chronic illness may alter hair growth. Certain medications, especially chemotherapy, commonly cause temporary hair loss. Hair loss itself can also provide important diagnostic clues. Later in this chapter, we'll discuss conditions such as traction alopecia, caused by repeated tension on the hair, and trichotillomania, in which individuals repeatedly pull out their own hair. For the NCLX-PN, remember these key points. Skin findings may reflect local skin disorders or systemic disease. Assess skin color carefully and consider variations across different skin tones. Congenital skin lesions are common and should be evaluated appropriately. Hair assessment provides important information about nutrition, disease, and medication effects. Always assess the skin, hair, and nails as part of a complete pediatric physical examination. As nurses, it's important to remember that the skin often provides the first clue that a child has an underlying medical condition. Some skin findings are harmless, normal variations, while others signal more serious systemic disease. The first finding listed is a vascular birthmark, or hemangioma. Hemangiomas are benign collections of blood vessels that often appear shortly after birth. They usually grow during the first year of life and then gradually shrink over several years. Most hemangiomas require only observation, but their location matters. Hemangiomas around the chin or lower face may extend into the airway and interfere with breathing. Those over the lumbosacral region may be associated with underlying spinal abnormalities and require additional evaluation. Next are hypopigmented macules, which are lighter areas of skin. One or two may be a normal variation, but multiple oval or ash leaf-shaped macules can be associated with tuberous sclerosis, a genetic disorder that can affect the skin, brain, kidneys, and heart. This is a good reminder that seemingly minor skin findings may point to an underlying systemic disease. The slide also shows the butterfly rash, which appears across the bridge of the nose and both cheeks while typically sparing the nasolabial folds. This rash is often photosensitive, meaning it worsens with sun exposure and may be associated with systemic lupus erythematosus, or SLE, an autoimmune disease. Finally, notice the scaling skin eruption around the mouth. A rash in a horseshoe-shaped distribution around the mouth, chin, cheeks, or perianal area, especially when accompanied by diarrhea and poor growth, should raise concern for zinc deficiency, also called acrodermatitis enteropathica. Early recognition is important because zinc supplementation can significantly improve symptoms. When assessing any skin lesion, consider more than just its appearance. Evaluate the location, color, size, shape, distribution, associated symptoms, and the child's overall condition. These details often help determine whether the finding is a benign skin condition or a sign of systemic illness. For the NCLX-PN, remember these key points. Some skin lesions are markers of underlying systemic disease. Most hemangiomas are benign, but those near the airway or lumbosacral region require closer evaluation. Multiple hypopigmented ash leaf macules suggest tuberous sclerosis. A butterfly rash over the cheeks and nose is associated with systemic lupus erythematosus. A scaling rash around the mouth, especially with diarrhea and poor growth, suggests zinc deficiency. Throughout this section, we'll discuss several common pediatric skin conditions that nurses frequently encounter in clinical practice. Although these disorders have different causes, they all require careful assessment, appropriate skin care, and family education. We'll begin with miliaria, commonly called heat rash, which occurs when sweat ducts become blocked. Next, we'll discuss intertrigo, an inflammation that develops in warm, moist skin folds because of friction and trapped moisture. We'll also cover seborrheic dermatitis, often known as cradle cap in infants, and diaper dermatitis, one of the most common skin conditions during infancy. For each of these conditions, you'll learn how to recognize the rash, prevent further skin irritation, and provide appropriate nursing care. We'll then discuss acne vulgaris, a very common inflammatory skin disorder seen during adolescence, including treatment options and patient education to help reduce scarring and improve adherence to therapy. Finally, we'll review herpes simplex virus type 1, which commonly causes cold sores. We'll discuss how the virus is transmitted, treatment options, and teaching points to help prevent spread to others. As you study each condition, ask yourself 4 questions. What causes it? How does it look on assessment? How is it treated? What education should be provided to the child and family? Keeping those questions in mind will make it much easier to compare these conditions and remember them for the NCLX, PN, and clinical practice. One of the most important bacterial skin infections seen in newborns is a staphylococcal infection, most commonly caused by Staphylococcus aureus. Because newborns have immature immune systems, these infections can spread rapidly if they are not recognized and treated early. The slide notes that the infection often begins at the umbilical stump or the circumcision site. These areas create small breaks in the skin that allow bacteria to enter the body. Infection may develop while the infant is still in the hospital or after discharge at home. The greatest concern is that the infection can spread beyond the skin and enter the bloodstream, leading to sepsis, a life-threatening systemic infection. This is why even a seemingly minor skin infection in a newborn should never be ignored. One important nursing point is that small pustules on a newborn should always be reported immediately. Newborns do not localize infections well, so a few small pustules may actually be the first sign of a more serious illness. Assessment findings may include redness around the affected area, pustules or blisters, drainage, warmth and swelling fever, or temperature instability, poor feeding, or lethargy if the infection becomes systemic. Treatment depends on the severity of the infection. Mild localized infections may respond to topical antibiotics, while more extensive infections or signs of systemic illness require intravenous antibiotics and close monitoring. The slide also mentions MRSA, or methicillin-resistant Staphylococcus aureus. MRSA is a strain of staph bacteria that is resistant to many commonly used antibiotics. If a hospitalized infant has MRSA, contact precautions are used to prevent transmission to other patients. This includes wearing gowns and gloves and practicing meticulous hand hygiene. From a nursing perspective, prevention is just as important as treatment. Careful hand hygiene, proper umbilical cord care, appropriate circumcision care, and prompt recognition of early signs of infection are essential in preventing serious complications. For the NCLX-PN, remember these key points. Staphylococcal infections commonly begin at the umbilical stump or circumcision site in newborns. Any pustules or signs of skin infection in a newborn should be reported immediately. Untreated infections can progress to sepsis. MRSA requires contact precautions in hospitalized patients. Meticulous hand hygiene is the most effective measure to prevent transmission. Another important bacterial skin disorder is staphylococcal scalded skin syndrome, or SSS. This condition is caused by certain strains of Staphylococcus aureus that produce toxins, which cause the outer layer of the skin to separate from the deeper layers. Unlike a simple staph skin infection, the bacteria may remain localized, but the toxins spread through the bloodstream, causing widespread skin involvement. The illness usually begins with fever, irritability, and redness of the skin. Early lesions often have a sandpaper-like texture, which is an important clue before blistering develops. As the disease progresses, large, fragile blisters or vesicles form. These blisters rupture easily, leaving behind a bright red moist surface that gives the appearance of a severe scald or burn. Because the skin peels away so easily, this condition is sometimes mistaken for child abuse or burn injuries, making careful assessment essential. One classic NCLX feature is the Nikolsky sign, where gentle pressure causes the superficial layer of skin to peel away. Although it is not listed on the slide, students should recognize this as a hallmark finding. Despite the dramatic appearance, the damage is limited to the superficial epidermis, so with prompt treatment, the skin usually heals without scarring. Treatment focuses on intravenous antibiotics to eliminate the staphylococcal infection, fluid and electrolyte replacement since skin loss increases fluid loss, pain management and gentle skin care, monitoring for secondary infection and dehydration. Nurses should handle the child carefully because the skin is extremely fragile. Maintaining a warm environment, protecting exposed skin, and using strict infection control measures are also important aspects of care. For the NCLX-PN, remember these key points. Staphylococcus aureus toxins cause widespread skin peeling. Early lesions feel like sandpaper before blistering develops. Fragile blisters rupture easily, exposing a bright red surface. The condition can resemble burns or child abuse, but generally heals without scarring. Treatment includes IV antibiotics, hydration, pain control, and careful skincare. Next is impetigo, one of the most common bacterial skin infections seen in children. It is a highly contagious infection that spreads easily through direct skin-to-skin contact or by sharing items such as towels, clothing, or toys. Impetigo is most commonly caused by Staphylococcus aureus or group A beta-hemolytic streptococcus, Streptococcus pyogenes. There are two forms students should recognize. Bullous impetigo is more common in infants and is usually caused by Staphylococcus aureus. It produces large fluid-filled blisters that rupture easily. Non-bullous impetigo is the most common form and is typically seen in children and young adults. It begins as small vesicles or pustules that rupture and form the classic honey-colored crusts, especially around the nose and mouth. Those honey-colored crusts are a favorite NCLEX clue. Newborns are especially susceptible because their immune system and skin defenses are still developing. Because impetigo spreads so easily, good hand hygiene, keeping lesions covered when possible, and avoiding sharing personal items are important nursing teaching points. Children are generally excluded from school or daycare until they have received at least 24 hours of appropriate antibiotic therapy, according to local public health recommendations. Treatment depends on the severity. Topical antibiotics such as mupirocin are used for localized infections. Oral antibiotics are used for more extensive disease. Severe or systemic infections may require intravenous antibiotics, although this is less common. For the NCLEX-PN, remember these key points. Impetigo is highly contagious, caused by Staphylococcus aureus or group A streptococcus, bullous form, infants, non-bullous form, honey-colored crusts. Teach hand hygiene and avoid sharing personal items. Treat with topical or systemic antibiotics, depending on severity. Next is infantile eczema, also called atopic dermatitis. This is one of the most common chronic skin conditions in childhood. It is not contagious and results from a combination of genetic factors, an overactive immune response, and a weakened skin barrier. Children with eczema have hypersensitive skin that becomes inflamed when exposed to certain triggers. During a flare, blood vessels dilate, causing redness, warmth, and itching. The inflammation leads to spongiosis, which means fluid builds up between skin cells. This creates tiny vesicles that may ooze, crust over, and eventually become dry and scaly. The slide mentions that eczema is rare in exclusively breastfed infants until additional foods are introduced. While breastfeeding may delay or reduce eczema in some infants, genetics remain the strongest risk factor. Eczema often occurs in children with a family history of asthma, allergies, or eczema, sometimes called the atopic triad. The most important symptom is intense itching. The itching leads to scratching, which further damages the skin and increases the risk of secondary bacterial infection, often with Staphylococcus aureus. Symptoms commonly worsen during the winter months because cold, dry air removes moisture from the skin. Treatment focuses on restoring the skin barrier and preventing flare-ups. Apply thick moisturizers or emollients several times a day, especially after bathing. Use lukewarm baths rather than hot water. Avoid harsh soaps, fragrances, wool clothing, and known triggers. Topical corticosteroids are used during flare-ups to reduce inflammation. Keep the child's fingernails short to minimize skin damage from scratching. For the NCLEX-PN, remember these key points. Atopic dermatitis is chronic, inflammatory, and not contagious. Severe itching is the hallmark symptom. Moisturizers are the foundation of treatment. Topical corticosteroids treat acute flare-ups, prevent scratching to reduce skin damage and secondary infection. Parent education is one of the most important parts of managing atopic dermatitis because eczema is a chronic condition with periods of flare-ups and remission. First, teach parents to use medications exactly as prescribed. The slide states that ointments should be washed off between applications. In practice, routine washing between every application is not necessary unless specifically instructed by the healthcare provider. Instead, apply medications to clean skin and follow the prescribed schedule. The slide also says that cortisone creams should be avoided because they do not resolve the underlying cause. This statement needs clarification. Topical corticosteroids are actually a mainstay of treatment for eczema flares because they reduce inflammation and itching. However, they should be used only as prescribed for the shortest effective duration, and parents should not overuse them because prolonged use can thin the skin. When applying topical medications, the best time is immediately after a lukewarm bath while the skin is still slightly damp. This helps lock in moisture and improves absorption. Apply creams and ointments in a thin layer, gently stroking in the direction of hair growth to minimize irritation. An easy way to teach parents the correct amount is the fingertip unit, which helps prevent using too much or too little medication. One of the biggest challenges is preventing scratching. Keep the child's fingernails short, use cotton mittens or socks over the hands for infants if needed, and dress the child in soft cotton clothing. The slide mentions elbow restraints. These are rarely used today and generally are not recommended except in unusual situations under medical supervision. Finally, parents should understand that topical steroids should not be applied to untreated viral skin infections, such as active herpes simplex lesions, because steroids can worsen certain infections. Any new rash that looks infected should be evaluated before continuing steroid therapy. For the NCLEX PN, remember these key teaching points. Moisturize immediately after bathing. Use topical corticosteroids exactly as prescribed during flare-ups. Apply medications gently in the direction of hair growth. Keep fingernails short to reduce skin damage from scratching. Avoid triggers and notify the provider if signs of infection develop. Next are fungal infections, also called tinea infections or dermatophytoses. These infections affect the outer layers of the skin, as well as the hair and nails, because the fungi feed on keratin. Unlike bacteria, fungi are eukaryotic organisms, which is why they require antifungal medications rather than antibiotics. The specific name depends on the location of the infection. Tinea capitis affects the scalp. It causes scaly patches with hair loss or alopecia, and may leave small black dots where hairs have broken off. Because the fungus infects the hair shaft, oral antifungal medication is required. Topical creams alone are not effective. Tinea corporis, commonly called ringworm, affects the body. It produces the classic ring-shaped, scaly lesion with central clearing. Despite the name, there is no worm involved. It is a fungal infection. Tinea pedis, or athlete's foot, affects the feet, especially between the toes. It causes itching, scaling, redness, and cracking. Keeping the feet clean and dry is an important part of treatment. Tinea cruris, commonly called jock itch, affects the groin and upper thighs. It is common in adolescents, especially after sweating or sports activities. Treatment depends on the location. Most skin infections respond to topical antifungal creams. Tinea capitis requires oral antifungal therapy because the medication must reach the infected hair follicles. Teach patients to complete the entire course of treatment, even if the rash appears better, and avoid sharing hats, combs, towels, or clothing. For the NCLEX PN, remember these key points. Tinea infections are fungal, not bacterial. Tinea capitis equals sign scalp with hair loss, requires oral antifungals. Tinea corporis equals sign ringworm with central clearing. Tinea pedis equals sign athlete's foot between the toes. Tinea cruris equals sign jock, itch of the groin. Next is pediculosis, which is an infestation with lice. Lice are parasites that survive by feeding on human blood and are spread primarily through close personal contact. There are 3 types of pediculosis based on where the lice are found. Pediculosis capitis is head lice, the most common type seen in school-aged children. Pediculosis corporis is body lice, which typically live in clothing and move to the skin to feed. It is more common in situations with poor hygiene or overcrowding. Pediculosis pubis is pubic lice, also called crabs, and is usually spread through sexual contact. The hallmark symptom is intense itching, which occurs because the body reacts to the louse's saliva. Children may also have scratch marks or secondary bacterial skin infections from excessive scratching. Diagnosis is made by finding live lice or nits, which are the eggs attached firmly to the hair shaft. Unlike dandruff, nits cannot be easily brushed away. Treatment includes Applying an approved pediculicide, such as permethrin 1% according to directions, removing nits with a fine-tooth nit comb, washing clothing, bedding, hats, and recently used items in hot water, and drying them on high heat. Items that cannot be washed can be sealed in a plastic bag for about 2 weeks. Household members and close contacts should be checked and treated if infested. One important teaching point is that head lice are not a sign of poor hygiene. They spread easily among children through close contact and shared personal items. For the NCLEX PN, remember these key points. Head lice are the most common form in children. Lice feed on human blood and cause intense itching. Nits are firmly attached to the hair shaft. Treat with a pediculicide and remove nits with a fine-toothed comb. Wash bedding and clothing in hot water and avoid sharing hats, combs, and brushes. Next is scabies, which is a parasitic skin infestation caused by the female Sarcoptes scabiei mite. The female mite burrows into the outer layer of the skin where she lays her eggs. These burrows contain eggs and mite waste, which trigger an allergic reaction and cause the characteristic itching. The hallmark symptom is intense itching that is much worse at night. Patients often scratch so much that they develop secondary bacterial skin infections. Scabies commonly affects warm, moist areas of the body, including between the fingers, wrists, axillae, waistline, groin. Buttocks, in infants, the head, neck, palms, and soles may also be involved. Scabies spreads through prolonged, close skin-to-skin contact. It can also spread through shared bedding, towels, or clothing, although this is less common. Treatment is permethrin 5% cream, which is applied from the neck down in older children and adults. In infants, it is often applied to the entire body, including the scalp, because the head is commonly affected. The cream is left on for the prescribed time, usually 8 to 14 hours, before washing it off. A very important nursing teaching point is that everyone in the household and other close contacts should be treated at the same time, even if they do not have symptoms. Bedding, clothing, and towels used during the previous several days should be washed in hot water and dried on high heat or sealed in a plastic bag if they cannot be washed. Parents should also know that itching may continue for several weeks after successful treatment because the allergic reaction takes time to resolve. Persistent itching does not necessarily mean the treatment failed. For the NCLEX-PN, remember these key points. Scabies is caused by the female mite that burrows into the skin. Severe itching that is worse at night is the hallmark symptom. Burrows are commonly found between the fingers and in skin folds. Treat with permethrin 5% cream. Treat all household members and wash bedding, towels, and clothing to prevent reinfestation. Now let's discuss burns, which are one of the leading causes of injury in children. Young children are especially at risk because of their curiosity, thin skin, and inability to recognize danger. Burns are classified by their cause, and there are 4 major types. The first is thermal burns, which are the most common in children. These result from flames, hot liquids, steam at or hot objects. Scald injuries from hot water, coffee, or soup are especially common in toddlers. The second type is chemical burns, which occur when the skin comes into contact with corrosive liquids or powders, such as household cleaners, drain openers, or industrial chemicals. The first priority is to remove the chemical and flush the area with large amounts of water, unless the chemical requires a different treatment. The third type is electrical burns. These occur when an electrical current passes through the body. Although the skin injury may appear small, there can be significant internal damage, including muscle injury and cardiac dysrhythmias. These patients require careful assessment and cardiac monitoring. The fourth type is radiation burns, which are less common in children. They may occur from radiation therapy or excessive exposure to ultraviolet radiation, such as severe sunburn. Regardless of the cause, nurses should first follow the ABCs: airway, breathing, and circulation. Children with burns involving the face or neck should be monitored closely for airway swelling. And larger burns require careful attention to fluid loss, pain control, infection prevention, and temperature regulation. For the NCLEX-PN, remember these key points. Thermal burns are the most common burns in children. Chemical burns require immediate removal of the chemical and copious irrigation. Electrical burns may cause serious internal injuries despite minimal skin damage. Radiation burns result from radiation exposure, including radiation therapy. Always assess the airway first, especially with facial or inhalation burns. Children respond to burns much differently than adults, and these differences make burn injuries more serious. First, children have thinner skin, so burns become deeper with lower temperatures and shorter exposure times. For example, hot tap water that might cause a mild burn in an adult can cause a deep burn in a young child within seconds. Children also have a larger body surface area relative to their weight, which means they lose fluids, electrolytes, and body heat much more quickly. This places them at higher risk for dehydration and burn shock. Their cardiovascular and immune systems are also immature, making them more vulnerable to shock, infection, and complications after a burn injury. Because burns create a hypermetabolic state, children have increased protein and calorie needs to support healing. If nutrition is inadequate, healing is delayed. Finally, because children's skin is more elastic and they are still growing, scar tissue can tighten over time, leading to contractures that restrict movement. Early physical therapy and proper positioning help minimize these long-term complications. For the NCLAX-PN, remember these key points. Children sustain deeper burns more quickly because their skin is thinner. They lose fluids and heat rapidly due to their larger body surface area. Burn children are at high risk for dehydration, shock, and infection. Adequate nutrition, especially protein and calories, is essential for healing. Prevent contractures with proper positioning, range of motion exercises, and rehabilitation. There are several additional reasons why burn injuries have a greater long-term impact on children than adults. Children have smaller muscle and fat stores, so if they cannot eat enough during recovery, they quickly develop protein and calorie deficiencies. Good nutrition is critical because wound healing requires large amounts of energy and protein. Children's skin is also more elastic and continues to grow, which means scars can tighten as the child grows. This increases the risk of contractures, where scar tissue limits movement of joints. Early rehabilitation, positioning, splinting, and range of motion exercises help prevent these complications. Another concern is that young children have an immature immune system, making them more susceptible to infection, which is one of the leading causes of complications after major burns. Finally, severe burns often require prolonged hospitalization, multiple surgeries, and lengthy rehabilitation. Long periods of immobilization can interfere with normal physical growth, motor development, and emotional well-being, making long-term follow-up an important part of pediatric burn care. For the NCLX-PN, remember these key points. Children have limited protein and fat reserves, so nutrition is essential for healing. Scar tissue can cause contractures as the child grows. Immature immunity increases the risk of infection. Burn recovery may affect growth and development, requiring long-term rehabilitation and follow-up. Burns are also classified by severity, which helps determine where the child should be treated and the level of care required. A moderate burn includes partial thickness burns involving 15% to 30% of the body surface area. Full thickness burns involving less than 10% of the body surface area. A major burn is more serious and includes partial thickness burns involving 30% or more of the body surface area. Full thickness burns involving 10% or more of the body surface area. Remember that both partial and full thickness burns are open wounds, placing the child at significant risk for infection, fluid loss, and heat loss. Larger burns also increase the risk of burn shock, so early fluid resuscitation and specialized burn care are often required. For the NCLX-PN, remember, burn severity depends on both depth and total body surface area, TBSA. Major burns require specialized treatment, often at a burn center. All significant burns are considered open wounds with a high risk of infection. Monitor closely for fluid loss, shock, and signs of infection. The 6 C's of burn care provide a simple way to remember the priorities of initial burn management. The first C is clothing. Remove any smoldering clothing or jewelry as soon as possible to stop the burning process. However, do not remove clothing that is stuck to the burn, because this can cause additional tissue damage. The second C is cooling. Cool the burn with cool running water for about 20 minutes if done soon after the injury. Do not use ice or ice water, as this causes vasoconstriction and can worsen tissue damage. The third C is cleaning. Gently cleanse the burn with clean water or saline to remove debris and reduce contamination. Avoid harsh scrubbing. The fourth C is chemoprophylaxis. Apply topical antimicrobial agents as prescribed to reduce the risk of infection. Large or deep burns may also require tetanus prophylaxis and systemic antibiotics if infection develops. The fifth C is covering. Cover the burn with a clean, dry, non-adherent dressing to protect the wound, reduce contamination, and decrease pain from air exposure. The final C is comforting. Burn injuries are extremely painful, so adequate pain management, emotional support, and reassurance are essential, especially in children. For the NCLEX PN, remember, remove clothing that is not adhered to the burn. Cool burns with cool running water, not ice. Keep the wound clean and covered with a sterile dressing. Prevent infection with appropriate wound care. Pain control is a priority throughout burn treatment. Electrical burns can be deceptive because the damage you see on the skin is often much less than the damage occurring inside the body. Always assess the child for both an entry wound and an exit wound. These injuries help identify the path the electrical current traveled through the body. The path of the current is important because electricity can damage muscles, nerves, blood vessels, and internal organs, even when the skin injury appears minor. If the current passes through the chest, it can affect the heart, increasing the risk of life-threatening cardiac dysrhythmias. For this reason, many children with significant electrical injuries require continuous cardiac monitoring. Electrical injuries can also cause deep muscle damage, leading to rhabdomyolysis, where damaged muscle releases myoglobin into the bloodstream. Myoglobin can obstruct the kidneys, increasing the risk of acute kidney injury, so maintaining adequate fluid intake and monitoring urine output are important. For the NCLEX PN, remember, always assess for both entry and exit wounds. Internal injuries are often much more severe than the external burn. Monitor for cardiac dysrhythmias after electrical injuries. Watch for muscle damage, rhabdomyolysis, and signs of kidney injury. Sunburn is one of the most common burn injuries in children and results from overexposure to ultraviolet UV radiation from the sun. The severity can range from a superficial, first-degree burn with redness and tenderness to a partial thickness, second-degree burn with blistering. Severe sunburns can also lead to dehydration, fever, and heat-related illness, especially in young children. The goals of treatment are straightforward. Stop further sun exposure by moving the child indoors or into the shade. Reduce inflammation and pain with cool compresses, cool baths, adequate fluids, and analgesics such as acetaminophen or ibuprofen, if appropriate. Rehydrate the skin by applying moisturizers or aloe vera products. Encourage increased oral fluids to help prevent dehydration. If blisters develop, they should not be broken, as intact skin helps reduce the risk of infection. Prevention is the best treatment. Children should wear protective clothing, hats, sunglasses, and broad-spectrum sunscreen with an SPF of at least 30. Sunscreen should be reapplied every 2 hours and after swimming or excessive sweating. For the NCLEX PN, remember, remove the child from further sun exposure immediately. Cool, hydrate, and relieve pain. Do not intentionally break blisters. Prevention with sunscreen and protective clothing is the best strategy. The priorities in emergency burn care are to stop the burning process, assess the injury, protect the wound, and get the child to definitive care. The first step is to stop the burning process. Remove the child from the source of the burn, extinguish flames, and cool thermal burns with cool running water for about 20 minutes if appropriate. Avoid using ice, as it can worsen tissue damage. Next, evaluate the injury. Follow the ABCs: airway, breathing, and circulation. Look for signs of inhalation injury, assess the depth and size of the burn, and identify any associated injuries. In electrical burns, remember to check for entry and exit wounds. Then, cover the burn with a clean, dry, non-adherent dressing or a clean sheet. This helps reduce contamination, decreases pain by limiting air exposure, and helps prevent heat loss. Do not apply butter, oils, or home remedies to the burn. Finally, transport the child to the hospital, especially if the burn is extensive, involves the face, hands, feet, genitalia, or major joints, is caused by electricity or chemicals, or if there are signs of airway involvement or shock. For the NCLEX PN, remember, stop the burning process first. Assess the ABCs before focusing on the burn itself. Cover burns with a clean, dry dressing, not ice, butter, or ointments. Prompt transport is essential for major burns or high-risk injuries. Once the child arrives at the hospital, the priority remains stabilization using the ABCs: airway, breathing, and circulation. The first priority is to establish and protect the airway. Children with facial burns or suspected smoke inhalation are at high risk for airway swelling. Warning signs include singed nasal hairs, soot around the mouth or nose, charred lips, hoarseness, stridor, or cyanosis. Because swelling can develop rapidly, an endotracheal tube may be inserted early before the airway becomes obstructed. Next, establish intravenous access. Children with major burns lose large amounts of fluid, so IV access is needed for fluid resuscitation, medications, and pain management. Blood and other body fluids are then collected for laboratory testing. Common tests include electrolytes, complete blood count, blood gases, kidney function, and other studies that help guide treatment and monitor for complications. Finally, a nasogastric NG tube may be inserted in children with extensive burns. Major burns can slow gastrointestinal function, causing stomach distension and increasing the risk of vomiting and aspiration. The NG tube decompresses the stomach and helps prevent these complications. For the NCLX PN, remember, airway is always the first priority. Early intubation may be needed before airway edema develops. Large burns require IV fluids and laboratory monitoring. An NG tube may be used to prevent gastric distension and aspiration in major burns. Wound care is one of the most important and often most painful aspects of burn treatment. Because comfort, pain medication should always be given before the procedure so the child is as comfortable as possible. Burn wounds require cleansing and debridement, which means removing dead tissue, debris, and bacteria. This helps reduce the risk of infection and promotes healing. Debridement may be performed mechanically, surgically, or with specialized dressings, depending on the severity of the burn. Another major concern is the loss of the skin's protective barrier. Without intact skin, children are at increased risk for infection, and they lose large amounts of fluid and heat through evaporation. This is why maintaining sterile technique, monitoring for signs of infection, and replacing fluids are essential parts of burn care. Throughout treatment, nurses also monitor the wound for healing, drainage, odor, color changes, and signs of infection, while providing emotional support to both the child and family. For the NCLX PN, remember, pre-medicate before dressing changes or debridement. Debridement removes dead tissue and promotes healing. Loss of skin increases the risk of infection and fluid loss. Strict infection control and ongoing wound assessment are essential. Frostbite is a cold injury that occurs when body tissues freeze after prolonged exposure to freezing temperatures. The areas most commonly affected are the fingers, toes, ears, nose, and cheeks because they are farthest from the body's core and lose heat first. A related but less severe cold injury is chilblain, also called pernio. Chilblains occur after repeated exposure to cold, damp conditions that are above freezing. They cause redness, swelling, itching, pain, and sometimes small blisters or ulcers due to damage from prolonged vasoconstriction. As the body is exposed to extreme cold, it tries to preserve heat by constricting blood vessels in the extremities. This reduces blood flow to the hands and feet so that the brain, heart, and other vital organs remain warm. If exposure continues, tissue freezing and permanent damage can occur. In severe cases of hypothermia with frostbite, the head and torso should be warmed before the arms and legs. Warming the body's core first helps restore circulation safely. Warming the extremities before the core can cause cold, acidic blood to return to the heart, worsening shock and potentially causing dangerous heart rhythm disturbances. As circulation returns during rewarming, the affected area often develops a deep red or purple color and becomes extremely painful. This severe pain is actually a positive sign that blood flow and nerve function are returning. Unfortunately, severe frostbite can lead to tissue necrosis or tissue death. If extensive tissue damage occurs, amputation may be necessary to prevent infection and preserve overall health. For the NCLX PN, remember these key points. Frostbite is freezing of body tissues caused by extreme cold. Warm the core before the extremities in severe hypothermia. Rapid rewarming with warm water is recommended only if refreezing can be prevented. Do not rub or massage frostbitten tissue because this increases tissue damage.